Yeah. Hi, good evening, doctors. Thanks for sparing your time today evening for the scientific session. Today's meeting's moderator will be Dr. K. Chandramohan sir. Chandramohan sir is a senior vitreoretinal surgeon at Vijayawada Mohan Retina Eye Hospital. Sir doesn't require any introduction because sir is a senior vitreoretinal surgeon in Vijayawada. Sir, with this, I would like to hand over the session to you. Please introduce speakers and please take the session forward, sir.
Yes. Good evening, all.
Good evening.
Anti-VEGF has been an important topic in the management of vitreoretinal diseases, and it is increasing day by day. So, to enlighten us on this topic, we have two young, enthusiastic retinal surgeons for tonight who will be presenting on their topics. The first speaker will be Dr. Lalita Amruta. She has done her MS Ophthalmology from Ramchandra Medical College, Chennai, Medical Retina Fellowship from Visakha Eye Hospital, Vizag, and she has 1 year experience working at Kakinada. And then currently she is working at Max Vision Eye Hospital, Visakhapatnam. She will be speaking on evaluation of anti-VEGF drugs, their molecular characteristics, and their impact on treatment success. Probably she will be comparing the molecular characteristics of different drugs and their advantages and disadvantages about their molecular characteristics. And I'll give the introduction to the second speaker also because I will not interrupt in between. Dr. Manasa, she's known well to me. So she has done her MBBS from SGRR Hospital, Dehradun, and she has done for her MS Ophthalmology from Minto Hospital, Bangalore. She has double fellowships. One is anti-segment fellowship from Shankara Hospital, Coimbatore, and she has vitreoretinal fellowship from one of my good friends, Dr. Nageshwar Rao from Vision Care Center for Retina in Bhubaneswar. And she is very enthusiastic in her clinical practice of vitreoretina. And she has the double FICO as well as FACO FICO fellowships also in vitreoretina. So she will talk on evolving role of efilbercept in PCV and comparison with other drugs. So these are the two topics for tonight today. Without wasting much time, I'll invite Dr. Lalita Amruta madam to proceed with her talk.
Thank you, sir. Thank you for your warm introduction. Good evening, everyone. And let me just share my screen.
Yes, madam. It's visible.
It's visible, right?
Yeah.
Okay, let me start. Today, my topic is about evaluating anti-VEGF drugs and its molecular characteristics and their impact on treatment success. This is a disclaimer and additional disclaimer showing how we got the details about faricimab from FDA.
Madam, your slides are not getting shared. Your video is coming now.
Oh, still.
Screen.
Screen share stopped, madam. Please reshare the screen.
Yes.
Okay.
Yeah, it's now.
Now, okay?
Yeah, now it's okay. You can make it a full screen, and then start.
Yeah, I made it already. Is it not coming yet?
Yeah, it's coming now. Now you can proceed.
Yeah, coming to the topic, in diabetes, there will be impaired vascular function and which leads to impaired retinal blood flow, which leads to hypoxia. And because of hypoxia, VEGF and placental growth factor are released. And this vascular endothelial growth factor will bind with VEGF receptor 1 and 2 in vascular endothelium, and it will cause increase in angiogenesis and neovascularization, further increasing vessel leakage and edema. And placental growth factor also increases inflammation, which will also increase the vessel leakage and edema. This is what generally happens in diabetes. Now, coming to aflibercept, if you see the structure of aflibercept, it's a fusion protein. It has three portions. One is VEGF receptor 1 domain 2. It binds with VEGF A, B, and placental growth factor. And the second portion is VEGF receptor 2 domain 3 binds with only VEGF A. These two will decrease the inflammation and decrease neovascularization, retinal vascular leakage, and edema. And the third portion is the FC portion of IgG1, which is responsible for extending half-life of aflibercept. So here, if you see, totally 4 components are getting targeted because of aflibercept. There is VEGF-A, VEGF-B, placental growth factor, and galactin-1. Galactin-1 normal pathway, it causes angiogenesis, but here aflibercept will act on the galactin pathway also and decrease the angiogenesis. Now we will see the molecular factors in 5 different categories. One is the binding affinity, then potency, then half-life, their targets, and molar dose. Coming to first one, it's binding affinity. In a study done by Schubert, he has compared KD, that is dissociation content coefficient for all these anti-VEGFs, these ranibizumab, brolucizumab, aflibercept, and faricimab. Here, what is meant by dissociation constant means it's a concentration of drug at which 50% of the target binding sites are occupied in equilibrium. So if the less amount of drug is needed, that will have best binding capacity, affinity. So whichever drug has lower KD value will have higher binding affinity. If you see the values here, aflibercept has 0.172 when compared with brolucizumab 1.3 and ranibizumab 21.8. Whereas faricimab, it's almost similar to that of ranibizumab. So whichever has the lowest KD value has the highest binding affinity. So aflibercept was found to be statistically higher VEGF binding affinity than the other two in this study. This is about binding affinity. Next, coming to potency. Here, the same person, Schubert, has used IC50 values of the anti-VEGFs. IC50 means half maximal inhibitory concentration. That means the concentration of the drug which is needed to reduce any biological activity or pathway which is going on normally by 50%. But it is done only in experimental studies, no in vitro. So here they have compared the values of aflibercept 2.42 and brolucizumab 5.74, ranibizumab 10.82. Faricimab data is not available as of now. So whichever has the lowest IC value will have increased potency. So aflibercept here again has most potency than compared to the other two in vitro. Third one is half-life. Here also they compared these 4 drugs. Brolucizumab having 4 to 5 days of half-life, ranibizumab having 7 to 9 days of half-life, faricimab 7 to 8 days, whereas aflibercept has 9 to 11 days. So aflibercept has more half-life when compared to other drugs. Then binding targets. We have seen already the 3 portions of the aflibercept. So it binds with VEGF-A, VEGF-B, placental growth factor, and galactin-1. So it has multi-target phenomenon. Whereas faricimab, it is a bispecific monoclonal antibody. So it basically binds with 2 factors, VEGF-A and angiopoietin-2. And the other brolucizumab and ranibizumab are just, they have single targets which they bind with VEGF-A. So in compared with all the 4 drugs, aflibercept is binding with 4 targets. So it has much more better binding targets than other. Now coming to exudative retinal diseases like diabetic retinopathy, diabetic macular edema, neovascular AMD. Generally, in patients with the DME, in a study done by Noma H. et al., they have observed 69 times increased VEGF levels and placental growth up to 19 times. So they have given aflibercept to these patients, and within the end of month 2, there is a drastic decrease in the values of both VEGF and PIGF in aqueous humor of the patients. So why normally we know about this VEGF? What is the importance of this placental growth factor? If there is increase in VEGF molecules, they inevitably they will increase the PAGF also. So only decreasing the VEGF molecules will not help in reducing the angiogenesis. So even decreasing the placental growth factor concentration also will help in reducing the angiogenesis. So let us see about additional pathways. Till now we have seen much about VEGF pathways. Now trying to see other pathways. So as we know, angiogenetic factors, they play a very important role in development of edema, retinal vascular permeability, inflammation, neovascularization, and this. Here, if you see, we have VEGF A, B, and placental growth factor. All these three, they act on VEGF receptor 1 and 2, and that will lead to all this leakage, inflammation, neovascularization, leading to macular edema. Whereas angiopoietin 1 and 2, generally in Tie2 receptor, angiopoietin 1 usually binds to Tie2 receptor, and it leads to stabilization of the endothelial cell proliferation, migration, survival, and inflammation. But if there is increased VEGF, it leads to increased angiopoietin 2 concentration. Now angiopoietin 2 will come and competes with the angiopoietin 1, and it binds with Tie2 receptor. So it destabilizes the pathway which should happen normally. So there will be increased endothelial cell proliferation leading to increased inflammation. Let's see much about angiopoietin 2 now. During angiogenesis, angiopoietin 2 is upregulated and it competitively binds with Tie2 receptor. Because of that, there will be increased the inflammation and neovascularization. So in high VEGF states, angiopoietin 2 antagonist activity may promote destabilization of blood vessels. In low VEGF states, induced by anti-VEGF treatment, angiopoietin 2 have very less role. So aflibercept is the most potent binder of VEGF compared to other available agents, because we have seen in the starting itself, because it has more less dissociation constant, it has more binding affinity. So it will decrease VEGF levels. Because of the low VEGF levels, angiopoietin 2 also decreases, and it decreases the neovascularization. Then a study done by Bayer and Regeneron in Ruby and Onyx studies, they have compared between faricimab and nesvacumab. Nesvacumab is a inhibitor of angiopoietin 2. They have compared the binding affinity of these two with Tie2 receptors. Nesvacumab dissociation coefficient is very less, 24, when compared to the faricimab. As we've seen before already, whatever drug with less dissociation constant will have much binding affinity. So nesvacumab has stronger binding affinity for angiopoietin 2 than that for the Tie2 receptor, whereas faricimab has a weaker binding when compared to that of nesvacumab. So in this Ruby and Onyx study is done in neovascular AMD patients, and Ruby study is done in diabetic macular edema patients. Here they have given nesvacumab plus aflibercept to few patients and aflibercept monotherapy to few patients. But at the end of 36 weeks, vision improvement was almost similar in both cases. So that proved there is no any additional benefits when they give nesvacumab additional to aflibercept. So monotherapy aflibercept is enough. Comparing other studies, here they have compared faricimab and aflibercept in DME and neovascular AMD. All these are the studies that are showing. But if you see at the end of the 48 or 256 weeks, both faricimab and aflibercept has shown similar increase in vision letters at the end of their studies. So showing that faricimab additionally targeting angiopoietin 2 doesn't really have any additional clinical benefit when compared with monotherapy with aflibercept. And then is other study, it's known as Avenue study. They compared between ranizumab and faricimab for decreasing the angiopoietin 2 levels in plasma after one injection. So they have compared after week 4, both ranizumab and faricimab showed similar decrease in angiopoietin 2 levels. So this data suggested that anti-VEGF monotherapy neutralizes angiopoietin 2 to levels comparable to that achieved when directly targeting angiopoietin 2. So instead of giving faricimab and directly targeting angiopoietin 2, just giving aflibercept single monotherapy also will decrease VEGF, which will cause angiopoietin 2 to decrease. That will not have much relevance. So faricimab failed to meet the primary endpoint of superiority to ranibizumab for best visual acuity at week 36. Levels of angiopoietin 2 inhibition were similar between these two agents, suggesting that anti-angiopoietin monoclonal antibody of faricimab may provide no additional benefit over anti-VEGF monotherapy. This is about our new study. There is one more study which compares between aflibercept, brolucizumab, and ranibizumab. Here they have seen that anti-VEGF generally prevents VEGF-driven angiotensin projection. But this anti-VEGF effect is more with aflibercept when compared to with brolucizumab and ranibizumab. So after this study, the results showed that angiopoietin 2 will always be expressed secondary to primary insults to retinal vasculature by VEGF. So if we decrease VEGF, it automatically decreases the angiopoietin 2. So direct inhibition of angiopoietin 2 may not be clinically relevant as this is currently provided by anti-VEGF treatment alone. Now comparing all the 4 drugs in the same chart. Aflibercept, it's a fusion protein. Brolucizumab is a single chain antibody fragment. Ranibizumab is the antibody fragment. Faricimab is bispecific monoclonal antibody. Here, if you see the dissociation constant, so it has the binding affinity better than the others. Next is the potency. Then it has 4 targets. Then half-life. All these are showing that aflibercept is much better than the other 3 drugs. Additional pathways which we have seen before, that nesvacumab plus aflibercept. And the second one is faricimab. Both have shown similar results with that of aflibercept. So the guidelines which recommend anti-VEGF as first line to treat center involving DME are this. Before, laser treatment used to show as a better treatment option, but now after getting anti-VEGFs, it is the best treatment available. And steroids are also important in these patients, but it's always a second level choice. Then some other randomized controlled trials with aflibercept in clinical practice are done by Moorfields in neovascular AMD patients. They showed vision gain maintaining through year 4 with proactive treat and extend dosing regimen. And Morimoto done a study in PCV people, and their vision gains were maintained through year 2 with a proactive treat and extend dosing regimen. And in Moorfield's study in DME patients, vision gains are achieved with a meaningful reduction in treatment burden after early and intensive dosing. So coming to summary, aflibercept targets where it matters, that is VEGF and placental growth factor. Therefore, it will decrease the downstream signaling through VEGF and PGF via VEGFR receptor 1 and 2. Which is the master regulator of the pathological angiogenesis. And we have seen the data, both preclinical and clinical studies, suggesting that there is no additional benefit of targeting alternatives to VEGFR signaling pathway, that is angiopoietin. Next, separate independent studies suggest aflibercept has a greater binding affinity for VEGF-A, a greater potency, and a longer half-life, as the study done in Schubert, than any other available anti-VEGF agents. These factors contribute to strong suppression seen with aflibercept. Thank you. Does anyone have anything to ask?
No questions in the chat box, madam. Very nice presentation. To take your discussion forward, what we understood from the presentation is definitely aflibercept appears to be better than Avastin, bevacizumab and ranibizumab. So now the only comparison is between brolucizumab and faricimab.
Yes,
So
sir.
what we understood is faricimab, this one, brolucizumab, is a larger molecule, a heavier molecule.
Yes, sir.
Uh,
Molar doses.
so the discussion was that since it is a heavier molecule, it acts as a longer half-life and it prolongs the duration of action. But in
Yes.
practice, the half-life of brolucizumab appears to be lesser when compared to efilbercept.
Yes, sir.
So that prolonged action of brolucizumab is not coming when compared to efilbercept. That is one thing. The next comparison is with faricimab. So actually, when the molecule came, we all thought it will be promising because all the anti-VEGFs, they act only on reducing the exudation, reducing the neovascularization formation. So no molecule targets the maturation of the vessels. So since the vessels don't mature, they keep on leaking, and then it needs multiple injections since there is no
Yes.
maturation of vessels. So we thought that when faricimab came, since it inhibits the other agent also, there will be maturation of the vessels. But in practical thing, there are two difficult tastes. One is the longer duration of action, the wow effect that comes with brolucizumab or efilbercept is not coming with faricimab. Means it is acting slowly over a period of time. And also there is not much of maturation of the vessels. Clinically, it also doesn't prolong its action for 3 to 6 months. Ideally, we would need a potent drug as well as a drug which acts for a longer time. But I think none of these drugs are acting for a longer time. So I think efilbercept, faricimab, and brolucizumab are comparable. And since efilbercept is acting on 2-3 agents, it might be slightly potent when compared to these two drugs. That's what we understood from the presentation.
Yes, sir. Yes,
You want
sir.
to add anything else in this, madam?
Nothing more than that, sir. Same thing, but some studies showed that aflibercept has only 4 to 5 days of half-life. But
Yes.
in general, when it coming to clinical practice, because of its binding affinity, it is staying for more longer, sir. So it is like 9 to 11 days. So some studies showed half-life is 4 to 5. Some studies are showing 9 to 11 like that. Even there is confusion between that also. But because of its higher binding affinity, it is seen to be for more days, sir. That's the one thing I wanted to add. Then this angiopoietin 2, as you said, sir, by specific agent, faricimab. But even I have given very less injections till now, sir. But I couldn't see any wow effect as I seen in aflibercept and valsartan, same as you said, sir.
Even I don't have much
In
experience with that.
Yes, sir.
Yeah.
That
Yeah.
in
Anybody?
sir, hello, sir. Sir,
Yeah, yeah.
in our regular practice, when we
Yeah.
see usually brolucizumab, once we inject it stays for three months. The drying effect. Whereas in the recent past, I have injected in many patients. With aflibercept, definitely it is better than ranibizumab, but it is when I am comparing, what I saw is it is staying for somewhere around 45 days.
Yeah, correct.
Is it because of this binding affinity or the size of the molecule? Here it is a large molecule, aflibercept, if you are saying. Whereas
No.
brolucizumab,
I think brolucizumab is
brolucizumab is
larger
more.
molecule compared to efilbercept. That
yeah,
is the reason why they say that it acts longer when compared to efilbercept. The
sir.
molecular size is larger.
Yeah,
See, what they say is since the molecular size is larger, clearance will be slow and it has a prolonged action. That is one thing. What aflibercept people say is since the binding is very strong when compared to brolucizumab, so it binds to large number of receptors and the potency is more. That's what is the argument between these two. But what I understood from clinical practice is
sir.
if you have for example, neovascular AMD, you have a pigment epithelial detachment. I think among all the three,
Aflibercept.
brolucizumab has got a very good effect
Yes, sir.
when compared to efilbercept is the next.
Yes.
Uh,
In DME, it is aflibercept.
DME, efilbercept is better when compared to that.
Yeah. Okay.
That's what I react. And we don't have any reaction as such. I have never faced any reaction with efilbercept.
Yes, sir.
Viginax also not very severe reactions I ever got.
I had two cases, sir, where post brolucizumab I have published it. 2 cases of vasculitis, but never with aflibercept.
Aflibercept is very safe molecule. I've never got any inflammation or reaction with aflibercept.
Yes.
So any other person wants to give any feedback in this regard? If no one is there to give any comments, then we'll move on to the next topic. Dr. Manasa?
Yes, sir.
Madam, you can start your...
Can you see my screen, sir?
Yeah.
Okay. And I'm audible, right? Yeah.
Yeah. Yes, you can proceed.
Okay. Good evening, everyone. I'll be talking about the evolving role of aflibercept in PCV, APVRS insights and comparisons with other anti-VEGF agents. So, polypoidal choroidal vasculopathy or PCV, it affects all ethnic population, but it is found to be more prevalent in Asian populations. The prevalence of PCV in Caucasian populations or even in our Asian populations may have been underestimated because we routinely do not do a ICGA, where we usually see the polyps in case of asymptomatic patients. So before I go into the treatment of PCV, I would like to give a brief introduction. PCV is a clinical entity distinctive from neovascular age-related macular degeneration. That's how it was initially described, consisting of subretinal polypoidal vascular lesions associated with serous and hemorrhagic pigment epithelial detachments. So it can have 3 presentations, either exudative variety, a hemorrhagic type, and a mixed type. Then so how do we diagnose polypoidal choroidal vasculopathy? On clinical examination, there can be presence of orange subretinal nodules with serous or serosanguinous PEDs. Usually there is bilateral involvement and poor response to anti-VEGF therapy. That is when we suspect the diagnosis of PCV. And the gold standard treatment for PCV is indocyanine green angiography, where we see a focal early hyperfluorescence with a branch vascular network. With presence of polypoidal dilatations. These polyps can be pulsatile, surrounded by a hypofluorescent halo and late geographic hyperfluorescence. On OCT, there is major criteria and minor criteria. Major criteria include sharp peak PEDs, ring-like lesion beneath the RPE and face RPE elevation. Minor criteria include a thickened choroid, multilobulated PED, and double layer sign. And on fluorescein angiography, though it is not diagnostic, sometimes we can find diffuse stippled hyperfluorescence and non-specific leakage patterns. And on OCT angiography, we can identify the branch vascular network or the polyps in some cases. So these are the pictures, the major criteria and the minor criteria. Like I told, the first picture is that of a peak PED, also known as an inverted V PED. The second one is a thumb-like PED, and the third one is a notch PED, which we, in most of the cases, this is what we see and diagnose PCV. And within this PED, if there is presence of these hyperreflective rings, these things are pathognomic of polypoidal choroidal vasculopathy. The fourth picture, it shows the double layer sign. The double layer sign essentially means that the RP layer, this the one shown with the red arrow, that is hyperreflective, along with a hyperreflective Brooks membrane. That is what causes the double layer sign. So now coming to the treatment part. So to 2025, APVRS gave guidelines on treatment of PCV. So most of the cases of PCV, we go with anti-VEGF. However, when the PCV presents with a large submacular hemorrhage or an active extrafoveal polypoidal lesion, we treat it differently. In case of a large submacular hemorrhage, we go with pneumatic displacement with or without vitrectomy, with or without tissue plasminogen activator. Or in case there is an active extrafoveal polypoidal lesion, we do a thermal laser ablation along with an anti-VEGF. So in most of our cases, what we usually do once the PCV is diagnosed with the OCT criteria, we go for anti-VEGF monotherapy or a combination therapy of anti-VEGF with PDT. So after giving the initial anti-VEGF, whatever we decide, ranibizumab, brolucizumab or aflibercept, we monitor the treatment response with OCT and with or without ICGA. If once the lesion is stabilized and there is complete regression, we try to treat and extend the regime. And in case of any persistence or recurrence of disease activity, we try to shorten the intervals between the anti-VEGF agents, or we try to combine the treatment with photodynamic therapy. In case we are using ranibizumab or some other Avastin and all, we try to switch to another anti-VEGF agent. So based on the APVRS guidelines, what we essentially understand is that anti-VEGF agents, photodynamic therapy, and combination treatments form the current standard of care for PCV, aiming to reduce the PCV lesions and improve the vision of the patients. So this slide has been beautifully explained by Dr. Lalita, and so essentially what this slide shows, I like to review, is that aflibercept has a higher binding affinity, has a higher half-life, and the number of targets that it acts on are multiple, as opposed to single target of brolucizumab and ranibizumab and dual targets of faricimab. So now the various studies of PCV, in that in 2016, in the Everest study, which was demonstrated that ranibizumab monotherapy and ranibizumab with photodynamic therapy, that is what Everest compared, and it found that ranibizumab with photodynamic therapy had better vision gains versus ranibizumab monotherapy. Then after that came the VIEW 2 study. In the VIEW 2 study, it demonstrated that patients with PCV and neovascular AMD can achieve similar vision gains with aflibercept monotherapy. Then the largest study which showed the effectiveness of aflibercept monotherapy is PLANET study. And PLANET established that aflibercept 2 mg monotherapy is as efficacious as an aflibercept with photodynamic therapy. So this slide shows how the PLANET study was done. So PLANET was a prospective sham control study where they compared aflibercept monotherapy with aflibercept plus active PDT. So what they essentially did was, in the PLANET study, all the patients, they were given 3 initial monthly doses of aflibercept, 2 milligram. After that, after these 3 months, the patients were randomized into 2 groups, one of which received active photodynamic therapy and the other received sham photodynamic therapy. So once these two were randomized, after that, in case the patient doesn't need any rescue treatment, then the injection was given 2 monthly, that is 8 weeks, every 8 weeks, and that is till the end of 1 year. And so at the end of 1 year, the primary endpoint, that is change in BCVA from baseline and safety outcomes were measured. After the end of 1 year, the aflibercept, if again there was no need for rescue treatment, then the injections were given every 3 months, and the study endpoint was at the end of 1 year. So at the end of what they found is that both the aflibercept monotherapy and aflibercept monotherapy with PDT had similar visual gains. And apart from that, what we can see here essentially is the injection burden or the treatment burden. In the first year, it is very low. That is, it is 8 injections. And in second year, it's approximately 5 injections. If we compare this to ranibizumab, it would be pretty high because we'll need 12 injections in a year. So then again, the same thing, this slide shows the importance of the treatment burden. The treatment burden at the end of 1 year is close to 4 injections, 4 to 5 injections, and it further reduces to 3 to 4 injections in the second year. So apart from the PLANET study, there is another study called the ALTAIR study, which tried to see the efficacy and safety of aflibercept dosed according to the treat and extend regime in patients with neovascular AMD and PCV. So here also we can see that the number of injections both in the PCV and the non-PCV subgroup are reducing significantly in the second year. So in the Altair study, what they did to what they used as the treat and extend regime, the criteria that they used was so when did they decide to shorten the treat and extend regime to a minimum of 8 weeks was when there was presence of persistent fluid, or if there was any decrease in vision, like decrease of vision of more than 5 ETDRS letters, along with a recurrence of fluid in OCT, an increase in the central retinal thickness of more than 100 microns, and any new onset vascularization, which was decided by the doctor investigating the case, any new macular hemorrhage, new fluid or persistent intraretinal fluid or subretinal fluid, as compared with the previous visit, as indicated by the total OCT scan area. When did they try to maintain the extended regime? Is when none of the criteria of the shortening were met, and plus there was residual but decreased fluid from previous visit. When did they extend the treatment gap between two injections? Is when none of the criteria of shortening were met and there was no fluid on the OCT. So essentially, similar proportions of patients with or without PCV were extended into intervals of more than 12 weeks, that is approximately 3 months, at the end of 2 years with aflibercept 2 milligram. So another study was done by Marco et al., who reported similar outcomes with aflibercept 2 milligram treat and extend regime through 2 years, regardless of the neovascular subtype. So again, in this we can see the number of injections in the second year is much lesser. So all these real world, even in the real world patients with PCV, we can achieve vision gains comparable to those in the randomized control trials which he saw. And what we understand is that there is, with the use of aflibercept, the durability of the treatment and the vision gain is better. Now again, with aflibercept monotherapy, there are multiple studies which have shown that there is complete polyp regression across studies of aflibercept monotherapy. So why is there a difference in all of this? That is because of variability in the polyp regression rates are different in because the assessment criteria is different according in different studies. So now coming to my clinical cases. So this is one patient who's an 80-year-old man who came to us. This is the first picture that you're seeing. This is after a few injections. I don't have the previous OCT scans. But what I want to show is that I started treatment in 2023. And this led again, so this is in approximately, so September 23, after injection, it comes down. This is what I gave ranibizumab. This is not aflibercept. I want to show you the treatment burden with it. So the patient from 2023, then in 24, then in 25, and there is regression and the edema keeps appearing again. And the patient finally was lost to follow-up in Jan 2025. So almost 8 injections, and the treatment burden is high. So we have higher tendency of loss to follow. So this is another patient. I just wanted to show this. I don't have a long follow-up. However, this is in November 25 where I saw this patient. She presented with floaters and metamorphopsia. Her vision was 6/9, but she presented with metamorphopsia. So you can see this is a peak PED. This is a hemorrhagic PED, which is seen inferiorly in an extrafoveal area, and with one injection of aflibercept, there was resolution of the PED, and this is immediately after the injection. Like you can see, it is within 1 month after the injection. After this, I have given 2 more injections to the patient, and she's maintaining the vision. And however, there was a breakthrough vitreous hemorrhage which also resolved on its own. So then this is another patient. I just wanted to show a neovascular AMD. This is not PCV, but just I gave one Eylea injection, and this is at day 15 after the injection, and this is at 3 months after we gave the injection, and the macula is dried until now. So next thing is coming to faricimab. So faricimab, what they did in the study was, in the study for 4 months they have given monthly injections, after which they have given the fifth injection at a duration of 2 months, after which they have tried to give injections every 4 months. In case there is a need for rescue treatment, then they have given monthly injections. However, the faricimab study, it is called the Salveen study versus the Planet study by aflibercept. The Salveen study was an open-label, single-arm, multi-center study where faricimab has been given, and it has not been compared to any other molecule. And here again, there is monthly loading doses. The mean change in BCVA from baseline, it averaged over weeks, that is 40 to 48 weeks. So ICG and OCT were used to grade polyp regression inactivation. Only 77% had a confirmed diagnosis of PCV. So I think one study which compared aflibercept with faricimab is Hara et al. And the initial visual acuity improvement at 3 months was better with aflibercept as compared to faricimab. And over the long run, there doesn't seem to be any advantage of faricimab versus aflibercept, and they both go hand in hand in terms of the vision gains. What Hara trial concluded is that both intravitreal aflibercept and faricimab treatments are effective in reducing exudation and retinal thickness. However, aflibercept was more likely to eliminate exudative changes and improve visual acuity in the short term. So, concluding, aflibercept 2 milligrams efficacy and safety profile has been established across multiple RCTs and is supported by over a decade of real-world pharmacovigilance monitoring. More than 20,000 patients from more than 20 countries are treated in real-world studies, and it has been approved in BRVO, CRVO, DME, CNV, and neovascular AMD. And with a lot of experience with aflibercept, and like sir was mentioning, the rate of inflammation, intraocular inflammation, is very low with aflibercept, and the rate of end-off is also very low. So the safety profile of aflibercept is also very high. Thank you.
That was a nice presentation, extensive presentation. A lot of studies were presented. And PCV is a variant of ARMD. When we were fellows, it was thought to be, it is a part of AMD. We thought some AMDs, wet AMDs behaved like that. But slowly the concept of PCV evolved. As you told, it is underreported actually. When we were fellows, we saw many cases, but we always thought they were wet AMD only. They are not PCVs. Only once the ICG came, we started diagnosing. But the problem with ICG is, ICG also initially, when the ICG came, the contrast was very less. So it was very difficult to pick up the polyps in the initial days. But once the Heidelberg came, actually that is the stage when we started diagnosing more number of PCVs in our practice. When we were in Arvind also, we had Topcon, we had Zeiss, but the number of cases which were picked up as PCV become more with Heidelberg thing, because the imaging has increased. But now it is very easy, as you told. It is now the criteria of OCT is very important. Even a small normal OCT, you don't need a OCT angiogram also. So if you have a normal OCT, if you have tall peak PEDs, thumb PEDs, or notched PEDs, then along with that, if you have hemorrhagic PEDs, then I think the only thing is why we have to identify this is the behavior of the disease is more. It is more aggressive. We can expect more sudden loss of visions in these patients. We can expect more subretinal bleeds and also more amount of breakthrough vitreous hemorrhages. And two of my experience I want to tell. Patients between 40 to 50, we have to keep this in mind. I had two cases of classic hemorrhagic PEDs. Thought they were, I think the two cases I gave anti-VEGF injection, they presented with total vitreous hemorrhages immediately following, sudden loss of vision. And later, when we examined the blood investigations, found to be leukemic. The two patients are found to be leukemic. So young patients are presenting with hemorrhagic PEDs. So be careful before jumping into conclusion that may be a PCV. That is one thing I just wanted to tell. Anybody else wants to give the feedback on this or any queries on this presentation on PCV?
Sir, this PCV bleeds, like when what I have observed is the when you people when we operate, the thing is even during surgery, it kind of is a very sticky blood and very sticky, and even the peripheral PEDs. So when you're operating and so studies are showing thermal ablation, they're telling for the PCV, but are we actually doing it, sir, for the
No,
entire lesion in case there's a peripheral?
Initial days of PCV, we used to do anti-VEGF and with direct focal laser to the polyps, extrafoveal polyps. We used to do
But sir,
IC and then
yes,
do it. But there is a danger of sudden hemorrhagic PEDs in this case, aggravation of disease. So it's not very advisable unless you identify the polyp very clearly. It's very risky to randomly do a thermal laser. Initial days we used to do extrafoveal polyps. We used to treat with direct focal laser along with anti-VEGF. But if you don't have a very good ICG, if you don't identify the polyp, if randomly give, it's a problem. Another good point you have raised is vitrectomy. If you want to do a vitreous hemorrhage vitrectomy, don't ever open try to drain the subretinal blood because it will not stop. So sometimes we will have making a diathermy and then aspirating the sub-RP blood, but it doesn't stop. It will continuously bleed. So in one of my cases, I had to close the case, and he had hyphema, and it's become a worse prognosis. So just remove the vitreous hemorrhage part of it, and then treat them with anti-VEGFs like Aflibercept. So we use anti-VEGFs rather than this. And my experience is Aflibercept. See, many of the studies also, they compare Aflibercept, Paginax, and even Vabysmo, they compare it with Aflibercept only. So the gold standard is Aflibercept, and they compare it with Aflibercept. So I think all three drugs will work with, as you told, chances of inflammation is less when with Aflibercept. But the potency of very sudden drying I felt is with brolucizumab, but I think duration is same with all the three drugs. That's my experience.
So the patient that I showed that there is a PED, hemorrhagic PED, which I've given 2 Aflibercepts, but usually we say that the macula should dry. Usually we are giving 3 monthly loading doses and all.
Yeah.
But when we have a peripheral extramacular thing and it has totally flattened that PED, does it make any sense to give those initial 3 injections, or we can just from the beginning go with the treat and extend model?
Treat and extend. See, the issue is what I understood from my practice is there is additive effect. For example, I'll give an example. For DME, I never gave continuous injections. So according to the studies, DME 8 injections to 12 injections in the first 1 year. So what happened is there was a patient who requested that he will go take anti-VEGF continuously till the OCT dries. So it was a very good case to me. So the OCT didn't dry for the first 4 injections. Means dry means there is only 10% decrease in thickness, or you cannot make out a difference. But between the 4th and 5th injection, 5th and 6th injection, sudden flattening of thing by 6th injection, the OCT became flat. So means that there is an additive effect of this anti-VEGF. So if you give like a test thing, the number of injections will come down in the next year. definitely the prognosis is better, and also the number of injections will come down and the disease will drive. See, clinically with first injection it has flattened, but there is an underlying disease which has not decreased, but it will come back. So if you keep on treating extra, one thing is the recurrences will be severely coming and you need more injections to control. But if you give the initial loading doses, the response will be better, the underlying disease will be addressed more better, and the number of injections on the long run will come down. That is the advantage of giving loading doses. The steady period, every steady, the DME or a wet ARMD, 8 to 10 injections in the first 1 year. That they told. If you do 8 to 10 injections according to the steady thing, in the next year, you will surprisingly need 3 to 4 injections only. So the initial stage of the disease, it slows down. But somehow the vasculature stabilized, or whatever reason it is, the next year, it becomes 3 to 4 injections. Most of the studies, the 5 years, they gave only 1 to 2 injections only. So that happens only if you give a loading dose and follow the test protocol. If you don't follow the study protocol, like treat and extend, see, most of the times it is treat and extend to me also, in most of the patients, treat and extend. But the only thing is the response is less, visual potential outcome is less, and number of injections keep on increasing. Every year you have to give 4 to 5 injections only. If you take in a steady protocol, you will have less number of injections in the coming years. That is one advantage of following the steady protocol. But it's practically very difficult to
counsel the patient.
And it is most of the times in clinical practice it's treat and extend only. Not only here, everywhere it is mostly treat and extend only.
Sir, another thing I want to add is that aflibercept for me, I mean vein occlusion, if it is a vein occlusion, I somehow try to push the patient to take aflibercept because somehow I feel that in vein occlusion, I am getting a very good response with aflibercept for 6 months straight. Like there is one patient, hemiretinal vein occlusion. Every year I give her in January and then in July. So it's like say 6 months, and that is essentially also happening when I am giving the entire that 0.1 ml full, like that becomes 4 milligram.
That's what the next dose is coming. No, next they are increasing the dose of the drug.
So probably that is what is increasing.
That will act better and longer, most probably.
Longer, yes.
Even I give the whole dose of the thing. I don't give 0.05 ml. Sometimes I give 0.1 ml to the drug. I just keep an air bubble so that if I push the drug within the needle also will go into the eye. So that it's 0.1 ml and it's 4 milligrams for the patient, for the benefit of it. It works a little longer than
0.05.
So if there are no other feedbacks, questions, then I think Srinivas.
Yes,
Srinivas?
sir. Yes, sir. Yes, sir.
Can we call it a day?
Yes, sir. Let me check in chat box. Yes, sir. Chat box also there were no questions.
Empty chat box and not much of discussion.
You cleared all the doubts, sir, at one go. It's you.
I didn't give time for the other speakers to talk, I think, most probably.
No, sir. Actually, yes, sir. Thank you so much, sir, for your wonderful moderation as usual. And thank you, Lalita madam and Mansa madam, for your wonderful talks. And thank you all the attendees who were sparing your today's evening, for this wonderful scientific conversation with the senior doctor like Chandramohan sir. And thank you so much, all. If there were no questions, it's good to close the call.
Okay. Thank you, Srinivas. Thank you, Bear, for giving this. Okay,
thank you, sir. Thank you, sir. Thank you so much.
Thank you.
Okay, ma'am. Bye, ma'am.
Bye.
Tech support, you can close the meeting.
Yes.